Okay, I welcome you, and I'm glad you come to this session. I am the chair, and I am the only live speaker. So, because Dr. Bollens could not come, and Dr. Kanda could not come. So I'm here to run the thing. So, and I hope you will help me for the discussion because it's not Zoom, so they cannot answer the questions. But, and I am not sure I can answer the question for them. Okay, so we will start, and I will introduce the first speaker, Jaap-Jan Bollens, who is very well known. He works at Sloan Kettering Hospital, and he will speak about long-term outcomes, including chronic GVH and quality of life. So, can you run the show?
First of all, I would like to thank the organizing committee for inviting me to talk about the long-term outcomes, including chronic GVHD and quality of life after cord blood transplant. I think this is a really important topic, and I hope I can convince you that the outcomes after cord blood are better than after the other cell sources. So the main message is that over the last decades, we have evolved to more precision transplantation. One size does not fit all. And I use this slide usually in the context of my PK and PD interest, but I think it also applies to selecting the optimal cell source for an individual patient. And with precision transplantation and cellular therapy, we will increase survival chances and improve the quality of life. The other messages I have for you today is that we need more long-term outcome analysis. Unfortunately, most of the research is only focusing on short and intermediate-term outcomes. And that cord blood transplantation survivors seem to do better. And that also has an impact on the financial burden. So I will discuss the outcomes after non-malignant transplant. I will give you two examples, MPS 1 and primary immunodeficiency, long-term outcomes in malignant diseases, a little bit on immune reconstitution and healthcare burden. So first of all, Hurler syndrome. Some of you know that I have an interest there, and we did some cell source comparison analysis and long-term outcomes. For those who are not familiar with Hurler syndrome is a lysosomal storage disease. And for the most severe clinical phenotype, Hurler syndrome, the outcomes are very poor. Early in life, mental retardation, orthopedic complications, blindness, deafness, resulting in premature death. Median age of survival is only 6 years. And with Duke University, Minneapolis, CIBMTR, Eurocord, and EBMT, we did an graft outcome analysis. We included data from the different databases, and we found that age at transplantation was a predictor for outcome, but also cell source and HLA matching. Match-ships and identical unrelated cord blood did best for the endpoint overall survival, while mismatched cord blood 4 and 5 out of 6 did similarly good, while mismatched mud did worst. We were not only interested in the endpoint survival, but also in donor chimerism. And I will explain later why. And in this slide, in the 260 patients included in this analysis, the patients who received an UCB, an unrelated cord blood donor graft, almost all these patients had full donor chimerism, and almost all of them had normal enzyme levels. while the other cell sources, and this is all after myeloablative conditioning regimen, unrelated donors, T-cell depleted unrelated donors, and identical SIPs, there was a fair amount of patients between 25 and 50% who ended up with mixed, let's say, chimerism, which resulted in lower enzyme levels after transplant. And why is this important? Well, I will show you in some of the long-term outcome analysis in a few minutes. And also in the patients who had full donor chimerism in this analysis, that were 152 patients. So this is this is a long-term outcome analysis. The enzyme levels after cord bloods on the y-axis here is significantly higher than the patients after bone marrow transplants achieving full donor chimerism at the latest follow-up time point. While the patients who had let's say, carrier matched SIP allo transplant ended up with the lowest enzyme levels after BMT. And why is this important? Well, we did a predictor analysis, late outcomes. A former PhD student, Mieke Aldenhover, saw all these patients in Europe and the US or North America, 217 patients. And the predictors for outcomes were, again, age of transplant, but also enzyme level after transplant. And I showed you that the enzyme levels after unrelated cord blood are higher, suggests that the patients, and also show that the patients after cord blood transplantations for Hurler syndrome did better. And here, cord compression and respiratory support as severe disease burdens after transplant. You can appreciate that IDUA, which is the alpha iduronidase enzyme, if you had below the lower limit of normal after transplant, the cumulative incidence to face cord compression after allo transplants was significantly higher than the patients who achieved an above lower limit of normal IDUA level. And the same is true for respiratory support. Those who had a below lower limit of normal enzyme level had a 40% risk to need respiratory support after transplant, while those who had normal enzyme levels did not. So mixed chimerism and lower enzyme levels after transplant as a consequence of this, and that includes being transplanted with an, let's say, carrier SIP transplant, results in a significant disease burden or residual disease burden after transplant. And here, this is a quality of life analysis in the patients with normal enzyme levels. And you can appreciate that the patients with normal enzyme levels had an unaffected psychosocial health score, while, and not shown on this slide, the patients who did not have normal enzyme levels had not a normal psychosocial health score after transplant. So it also impacts the quality of life of these patients. From MPS 1 patients to primary immunodeficiency patients, actually focusing mainly on SCID patients. And this was a Eurocourt EBMT analysis in blood 2012. And they compared alternative donors, mismatched haplo donors with unrelated cord blood donors. There was not an equal distribution in these almost 250 SCID patients. There were more T minus B plus patients, as well as more Omen syndrome patients in the cord blood group, and these patients tend to do worse after transplant compared to the haplo group. When you look at survival on the right-hand side, there was no impact on survival. When you look on the left-hand side at the immune reconstitution endpoint, there was no impact on immune reconstitution. However, there was an impact on the endpoint discontinuation of IVIG according to cell source after transplant. The patients who got a cord blood transplant tend to be off intravenous immune globulin dependency after transplant more often compared to the patients who got an haplotransplant. Also important to note is that the patients who got an haplotransplant were transplanted only in 4 centers, highly experienced centers, while the cord blood transplant recipients were done in multiple centers. I think, I can't recall the exact number, but between 20 and 30 different centers. So no difference in survival, but a better correction of the immune deficiency after cord blood. So I showed you 2 examples as non-malignant transplants. Now I will zoom in on malignancies in pediatric and adults. And there was one big cell source comparison analysis done in acute myeloid leukemia in pediatric patients. 8 centers contributed to this analysis. And we compared matched SIPs with MUDs and single cord blood and double cord blood. The diseases were not equally distributed between the different groups. The patients who received an unrelated cord blood tend to have a higher risk stratification before transplant and were more often in CR2 compared to the patients who got a matched SIP or a MUD transplant. The main outcome of interest was adjusted chronic GVHD-free, leukemia-free survival. And you can appreciate that the patients who got an umbilical cord blood did similar to the matched SIP donors, but significantly better than the patients who got a matched unrelated donor transplant. And this was mainly due to a lower grade, this was mainly due to lower chronic GVHD in the patients who received an unrelated cord blood transplant. While the grade 3 to 4 GVHD was even a little bit higher in the cord blood, the chances to develop chronic GVHD were significantly lower in the cord blood setting. The Seattle group did an alternative donor transplant analysis recently. They compared cord blood with haplo PTSI with mismatched unrelated donor recipients. Endpoint survival or leukemia-free survival was similar between the various cell sources, maybe a little bit higher in cord blood. When you look at the cumulative incidence for chronic GVHD, this was lowest in cord blood and haplo-PTSI compared to mismatched MUD. This was highly significant. Also, the disability rate was significantly lower in cord blood as well as in haplo compared to the mismatched MUD. The chances to come off immune suppression was highest in cord blood and haplo. The percentage of patients back to school work after cord blood or haplo was significantly higher compared to the mismatched MUD. So this suggests that the cord blood as well as the haplo-PTSI do better as alternative cell source compared to the mismatched MUD. Important and interesting note is that the severity of chronic GVHD in the cord blood was lower compared to the mismatched MUD as well as the haplo, where 25% of the patients had severe chronic GVHD, while this was only 3% in the cord blood recipients. So this is Filippo's paper, and I included this in the presentation also to show you again that in MRD plus patients, the survival is better due to lower relapse. You can appreciate that on the lower, let's say, curve on the right-hand side, and that is not impacted or associated with an increased chronic GVHD. So apparently, after cord blood, disease control is better in the MRD plus patients without an increase in, let's say, chronic GVHD. Two other papers I'm going to show you here. This is both Blood Advances 2020. This is in, let's say, adults. This is not a head-to-head comparison, but so it has its, let's say, caveats, but it's two separate, let's say, papers, but the patient characteristics were similar. This is haplo-PTCy from Heather Simons on the left-hand side and Juliet Barker on the right-hand side. You can appreciate that the disease control seems to be better in the unrelated cord blood setting, with only 9% relapse and a transplant-related mortality of 15%, while the relapse probability in the haplo-PTCy is over 40%. Again, there are some caveats because this is not a head-to-head comparison. But again, you can appreciate here that also the chronic GVHD is pretty low in the cord blood setting. This is an MSK comparison. This is between T-cell depletion and unrelated cord blood. And the chronic GVHD rates here were low in both transplant platforms, but you can appreciate that apparently in the cord blood setting, in this analysis, MRD is not a predictor for survival. So MRD plus and MRD negative cord blood recipients do similarly good as matched as unrelated donor transplantation who are MRD negative. Those who were MRD plus did significantly worse in the T-cell depletion group. So why better disease control? There's a lot of hypotheses. The London group, the GOS group, showed a couple of years ago in blood that the cord blood T cells mediate an enhanced anti-tumor effect. And this is in vitro, this is in an experimental model. But apparently these cord blood T cells exert, or this suggests that cord blood T cells exert an better anti-leukemic, anti-cancer efficacy compared to adult T cells. And I think that's a nice bridge to immune reconstitution, because I would like to share a couple slides on immune reconstitution after cord versus other cell sources. On the right-hand side in the red box, you can appreciate, and this is in pediatric young adults, the cumulative incidence of immune reconstitution, CD4 immune reconstitution, between cord blood and bone marrow transplant. And you can appreciate that after cord blood, in the absence of ATG, the CD4 reconstitution is pretty fast and happening in almost all recipients of cord blood. And faster and better than in the bone marrow setting. However, if there is some ATG exposure after transplant present in the system, the immune reconstitution is significantly hampered in the cord blood setting, while in the bone marrow setting, only in the setting of higher ATG exposure, the immune reconstitution is impacted. And are these cells also functional? Because you can argue, yeah, this is mainly naive T cells. Again, the London group GOS in London looked at viral reactivations according to cell source. And you can appreciate in this analysis in the red box that in cord blood without ATG or without alemtuzumab, the cumulative incidence of viral reactivation is lowest compared to the other settings, including bone marrow without serotherapy. And that's true for CMV, adeno, and EBV. So this suggests that in the setting that these T cells are functional and capable of controlling viral reactivations after transplant. And my lab in Utrecht, when I was in Utrecht, showed in a similar analysis, also in blood, a couple of years ago, that the viral reactivation rate, which was defined as having more than 1,000 copies per ml, was not seen in the patients who got a cord blood transplant without ATG. This is a slide from the memorial group, again from Dr. Barker and Dr. Politicos, and you can appreciate that also in the adults, in the absence of ATG, the immune reconstitution is very fast after transplant, with CD4s at 3 months around 200. So I've shown you that unrelated cord bloods, let's say T cells, can reconstitute pretty fast in the absence of ATG. But sometimes, in particularly in the non-malignant setting, it's tough to avoid ATG. So are there strategies to optimize that? And the answer is yes. So there was a recent prospective clinical trial results, let's say published in Lancet Hematology, where they have individualized the ATG dosing. And on the right-hand side, the primary endpoint was CD4 reconstitution, defined as more than 50 per microliter before day 100. And you can appreciate that in the individualized dosed patients, the immune reconstitution is faster. And although not powered for the endpoint overall survival, you can appreciate that overall survival is trending to be higher in the individualized ATG dosing group. Cord blood recipients as well as bone marrow recipients were enrolled on this trial. And you can appreciate in this slide that after cord blood in blue, the immune reconstitution in individualized ATG is better compared to the weight-based dosing done before. Almost 90% of the patients who received individualized ATG achieved CD4 reconstitution by day 100. A couple more slides on overall survival and non-relapse mortality of this paper. In the presence of CD4 reconstitution in the old way of weight-based dosing, as well as the individualized way of dosing, you can appreciate that the overall survival is better. And this is mainly due to lower non-relapse mortality. If you attain CD4 reconstitution within 100 days, your hazard ratio is 5 times lower, resulting in a significantly lower non-relapse mortality compared to those who did not achieve CD4 reconstitution. There was no impact on grade 2 to 4 GVHD with this individualized way of dosing. And actually, there seems to be a trend to lower moderate severe GVHD with the individualized dosing, and also a trend to lower graft failure. So let me wrap up with some impact on healthcare burden after cord blood transplants compared to other cell sources. And this was a nice analysis done by the Minneapolis group. Almost 1,100 patients were enrolled in this analysis. About 100 received bone marrow transplants, 500, almost 500 mobilized blood, and about 500 unrelated cord blood. The groups were not completely equally distributed. There was an age difference with a little bit younger in the bone marrow group compared to the mobilized blood group. And there tend to be more AMLs in the unrelated cord blood group and more chronic myeloid leukemia in the bone marrow group. And obviously, all the cord bloods were unrelated, while the mobilized blood and the bone marrow also included related donors, up to more than 90% in the mobilized blood group. So here are the outcomes, univariate analysis. So the GVHD-free, leukemia-free survival was similar between bone marrow and cord blood and was lowest in the mobilized blood group. Chronic GVHD was highest in the mobilized group compared to the unrelated and the bone marrow group. That relapse and new malignancies were similar in the three different, let's say, groups, but mainly the various toxicity endpoints were different. And how did that impact healthcare burden after transplants? And here you can appreciate the in and outpatient visits in figure 1, the lab studies in figure B, the medication orders in figure C, and the RVU builds in figure D. And what you can appreciate here, it's maybe a little bit a lot of information, but it suggests that the healthcare burden after cord blood, in particularly on the long term, after 1 to 5 years, is lowest. And that's maybe easier to see in this composite analysis, healthcare burden score, that after 100 to 1 year, as well as between 1 and 5 years, in red, the healthcare burden score, a composite, is lowest compared to the other cell sources. And they also did a multivariate analysis, and in A, the early days after transplant up to 100 days, in B, the 100 to 1 year analysis, and in C, the 1 to 5 year analysis. And you can appreciate that unrelated cord blood scored lowest, in particularly in the 1 to 5 year, but also in 0 to 100 days compared to bone marrow, and as well as in 100 days to 1 year after transplant. So this data suggests, and I think we would like to see more of these kind of analysis, that after 100 days, the cord blood recipients had the lowest healthcare burden compared to the other cell sources. So this brings me to the conclusion of this presentation. First of all, we need more long-term outcome analysis. Again, as mentioned earlier, most research focus on short and intermediate term outcomes. And I showed you, and I hope I've convinced you, that the cord blood transplantation survivors seems to do better. I showed you data on the non-malignants, on the malignants, pediatrics, and adults. There seems to be less chronic GVHD. There seems to be a better functional immune reconstitution after transplantation, and that all impacts financial burden as well. So we need better collaboration, and I think we need better alignment of practice. Over the last couple of years, we have published a couple of guidelines how to treat cord blood recipients, and I think we absolutely need to continue to do that. And preferably, it would be great to have a couple of retrospective projects, but also prospective analysis, if possible. And with that, I would like to thank my team at MSK, the adult program at MSK, and all the various collaborative centers. And I would like to thank you as well for your attention.
Because he's not here, but maybe somebody will transmit that. And I will call for the next speaker, is Dr. Kanda. So if you could put his presentation. He's also remote. In fact, he canceled at the last minute because he didn't have the authorization from the University of Japan because of the increase of the number of COVID infections. So we are not finished with that. So next, can you?
Hello,
okay.
everyone.
So the title of his talk is Advantage of Cord Blood Transplantation over Other Source, and it's a study of the Japan registry analysis.
Thank you very much for giving me an opportunity to make a presentation regarding the UCBT studies in Japan. Today, I'm going to talk about advantages of cord blood transplantation over other sources in Japanese registry analysis. I don't have any relevant conflict of interest to this presentation. This is a roadmap of my talk today. First, I would like to talk about trends of UCBT in Japan, and then recent improvement of conditioning regimen for CBT. And finally, I will talk about UCB versus other stem cell sources. With the development of GBT prophylaxis of post-transplant cyclophosphamide, like the Western countries, the number of haplotransplantation remarkably increased since 2020 to 2010 in Japan, and is now over the number of HLA match-related transplantation. However, the number of UCBT is still also increasing in Japan, and almost 1,500 per year in 2020, whereas the number of unrelated BMT and PBSCT slightly decreased. The reason of the increase in the number of UCBT is the improvement of neutrophil engraftment and management of early transplant complications, probably due to better UCB selection, conditioning regimen, and GvHD prophylaxis. Furthermore, coronavirus pandemic partly contributed to the increase of UCBT and decrease of unrelated BMT PBSCT in 2020. These figures showed early transplant outcomes within 100 days after single UCBT. OS, NRM, and neutrophil engraftment within 100 days after transplantation continue to improve in these 20 years. These figures show long-term transplant outcomes after single CBT. OS and NRM significantly improved over the past 20 years, mainly due to the improvement in day 100 NRM. If cohorts are limited to those who survived at least 100 days post-transplantation, there was no improvement in survival over the past 20 years. In Japan, double cord blood units are not allowed in clinical practice because previous studies in Japan showed that there was no advantage in double UCBT. First priority is to choose cord blood unit is the number of CD34 positive cells and then TNC. We select single UCB with CD34 positive cells more than 0.5 times 10 to 5 per kilo and TNC 2 times 10 to 7 per kilo. We select 021, 022 antigen mismatch at HLA-A-B-DR loci and 124 allele mismatch at HLA-A-B-C-DR1 loci. In our data, 8 allele match was associated with high risk of relapse, probably due to real graft versus leukemia effect. Then, I want to focus on conditioning regimen for single CBT in Japan. Representative conditioning regimen for UCBT are TBI-CY or high-dose RC CY-TBI for MAC regimen, which is established by Tokyo Institute of Medical Science, and flu male 80 mg per square TBI 4 gray for week regimen, which is established by Tranmon Hospital. However, myeloablative flu-bu 12.8 mg per kilo TBI 4 gray and flu-bu 12.8 mg per kilo male 80 mg per square are now increasingly used for high-risk myeloid disease patients, expecting stronger antitumor effect. Further, flu-mel TBI is also used as MAC regimen. Good result after myeloablative flu-bu-mel regimen for UCBT was first reported by Dr. Yamamoto and his colleagues in Tranmon hospitals. They showed that flu-bu-mel regimen offered high neutrophil engraftment and high overall survival in non-remission myeloid malignancies. Based on this study, flu-bu-mel regimen for CBT was now frequently used for high-risk myeloid malignancies in Japan. This study compared flu-bu-TBI with flu-bu-mel regimens in cohorts including mainly AML, MDS, and CBT. As shown here, flu-bu regimen, which is red line, showed better OS and lower relapse and comparable non-relapse mortality as compared with flu-bu-TBI regimen. This group then compared conventional myeloablative conditioning regimen such as TBI-CY or Bu-Cy with flu-bu-mel regimen for non-remission AML. They used propensity score matching to reduce biases between the two cohorts. The cohort included only non-remission AML, and cord blood unit was used in 70% of the cohort. As shown here, flu-bu-mel regimen showed better OS, lower relapse rate, and comparable non-relapse mortality. Interestingly, grade 3 to 4 acute GVHD was higher in flu-bu-mel regimens. Additional analysis showed that the more blasts, the better results were obtained in flu-bu-mel regimen as compared with conventional MAC regimens. These studies showed flu-bu-mel regimen is effective for non-remission AML. So next question is whether flu-bu-mel regimen is effective for remission AML. This study compared conventional MAC regimen and flu-bu-mel regimen for remission AML in cord blood transplantation. No difference was observed in log-rank test in OS, relapse, non-relapse mortality. However, the multivariate analysis showed that flu-bu-mel regimen was associated with better overall survival as compared with Cy-TBI regimen. These studies showed that flu-bu-mel regimen could take place of conventional MAC regimen in cord blood transplantation. Let's move on to the topic on comparison between UCB versus other stem cell sources. These figures show the difference in overall survival between matched-related or unrelated transplantation and CBT in Kyoto University. As shown here, outcomes of CBT was comparable in standard risk diseases, but was much better than that of the matched-related or unrelated drug transplantation in high-risk diseases. The reason for better overall survival in high-risk diseases might be GVL effect. As shown here, relapse incidence was apparently lower in CBT in high-risk diseases, suggesting stronger GVL effect in UCBT. Our findings were further validated by Japanese registry data analysis. Shimomura et al. Compared CBT and MRD transplantation in non-remission AML. They used propensity score matching to reduce biases between the two cohorts. As shown here, progression-free survival was better and relapse was lower in UCBT cohort, supporting the finding in Kyoto University. We showed that CBT was associated with better overall survival than matched donor transplantation in high-risk malignancies. Next question is whether we should choose UCB or haploidentical donor as an alternative donor in standard or high-risk diseases. Therefore, we compared transplant outcomes of UCBT and PTCY haplo in Kyoto University affiliated hospital. These figures show comparable outcomes of UCBT and PTCY haplo as for OS, RF relapse-free survival, and GRFS. The incidences of relapse and non-relapse mortality was also comparative between UCBT and PTCY haplo transplant groups. This table shows subgroup analysis of disease and disease risk. Subgroup analysis showed that relapse risk of UCB was significantly lower than that of the PTCY haplo in acute leukemia. This suggests that choice of donor may depend on disease and disease risk. Then, UCB and PTCY haplo was compared using national registry data. The disease included in this study were AML, ALL, and MDS. The Kaplan-Meier curve was superimposed between the two cohorts, meaning that the finding in our study was compatible with the registry data analysis. These are cumulative instances of relapse and non-relapse mortality. Relapse incidence was significantly lower in UCBT cohort, whereas non-relapse mortality was higher in UCB cohorts. These figures show cumulative instances of acute and chronic GVHD. Grade 2 to 4 acute GVHD was significantly highest in CBT. However, there was no difference in grade 3 to 4 acute GVHD and chronic or extensive type chronic GVHD. Completely the same. So, next question is whether we should decide stem cell source based on disease risk or not. Cohorts were divided by defined disease risk indexes. As shown here, OS tended to be better in PTCY haplo for low and intermediate risk. However, there was no significant differences for high and very high disease risk indexes. According to these two studies, we still could not reach a firm conclusion, but we can say that relapse risk is higher and non-relapse mortality is lower after PTCY haplo compared with UCBT, and these offset merits of PTCY to some degree, and we should choose cord blood for high-risk diseases. In my center, I usually select unrelated BMT or PBSCT for low-risk diseases and select UCBT for those who cannot find unrelated donor or those with high-risk diseases. So I experienced only a few cases of PTCY haplo in my university. We showed that low relapse risk after UCBT. So next question is the association between the occurrence of GVHD and transplant outcomes, including relapse. Using Japanese registry data, we analyze the effect of GVHD on transplant outcomes. These figures show the impact of acute GVHD on OS in pediatric and adolescent adult cohorts. As shown here, grade 1 to 2 GVHD, red line, was not associated with better OS in pediatric cohort, whereas this was associated with better OS in adult cohorts. These figures show the impact of acute GVHD on OS in matched sibling donor, matched unrelated donor, and UCB cohorts. As shown here, the better impact of grade 1 to 2 GVHD was not observed in matched sibling donor and matched unrelated donor, but it was observed in UCB cohort, this line. These figures show the impact of acute GVHD on relapse rate in matched sibling donor MAD UCB. As shown here, grade 1 to 2 GVHD did not reduce the relapse incidence in matched sibling donor and matched unrelated donor, but this reduced the relapse incidence in UCB cohorts. Therefore, UCB may be preferred as an alternative stem cell source expecting GBL effect in Japan. The effect of acute GVHD on overall survival are shown in Japanese and European cohorts. Interestingly, the better effect of acute GVHD on OS was observed only in Japanese cohort. We could not find the direct reason for the differences, but I suppose that the frequent use of ATG in European countries might have an effect on these differences. Next, using Kyoto University affiliated hospital data, we analyze the impact of GVHD on overall survival in PTCY haplo, UCB, and matched donor transplantation. As shown here, like UCB cohorts, mild acute GVHD was associated with better overall survival also in PTCY cohort. On the other hand, there was no difference in matched donor transplantation. The effect of acute GVHD on relapse was not different regardless of the occurrence of GVHD, probably because heterogeneous diseases were included in our cohort and may not be appropriate for the assessment of relapse. On the other hand, as for NRM, the occurrence of mild acute GVHD was associated with lower NRM PTCY and UCB cohorts. This may be explained by the better immune recovery for patients with very mild GVHD in PTCY and UCB cohort, but we don't have detailed immune recovery data and could not analyze it. As for chronic GVHD, limited type chronic GVHD was associated with better OS in PTCY haplo, UCB, and matched transplant cohorts. So, in summary, the number of UCB is increasing in Japan due to improved UCB outcomes and the COVID pandemic. Fluvial regimen for UCB offers better tumor control than other conventional MAC regimens. And relapse-free survival in CBT was significantly better than that in matched donor transplantation in high-risk diseases. UCB and PTCY haplo outcomes are comparable, but UCB could be a good choice for those with high-risk diseases. And grade 1 to 2 acute GVHD was associated with better OS only in Japanese cohort who received single UCBT. The same effect was also observed in PTCY haplo cohort. Finally, we thank all physicians and data managers who contributed valuable data to EBMT Eurocode, JSTCT, JDC, HCT. We also thank all members of Eurocode LWP of EBMT and JSHCT, JDC, HCT, and Kyoto University Transplant Team. And thank you very much.
As you know, there will be no question for these two talks. If you have burning question, I might try to answer, but I'm not sure. But if you have a very important question, you can still send a mail or message to them, and I'm sure they will be happy to answer. I'm sure they regret of not being here, but life is life and they could not come. So I will give the last talk, which is entitled Secondary Malignancy in cord blood transplant recipients. And here you have the name of the collaborator of this study. It's a Eurocord EBMT study. We know that there is a high risk for secondary malignancy in long-term survivors after hematopoietic stem cell transplantation, and there is 2 to 5-fold increased risk compared to their age-matched controls. The cumulative incidence of secondary malignancy continues to increase with longer follow-up after transplant with no plateau. It's approximately 1 to 6% at 10 years and 2 to 15% at 15 years. Usually, the prognosis is poor, with a high rate of secondary malignancy-related death in recipients of allogenic transplant. There are different types of malignancy, and they are post-transplant lymphoproliferative disorder, and this appears early after transplant. It can be the relapse of the primary disease. It can be second hematological malignancy, which appear later, and secondary solid tumors, which appear even later on. There are many risk factors for secondary malignancy. They are the result of interaction between transplant and related factors, conditioning regimen, T-cell depletion, use of ATG. It can be patient-related factors, age, gender, and disease-related factors, type of disease, stage of the disease, and the pre-transplant treatment. GVH, immunosuppression, infection are also factors which can increase the number of complications. And for patient-related factors, genetic predisposition and lifestyle aspect can increase the complications. So we have 3 different complications. It can be pre-PTLD, and there are pre-transplant factors, which are the pre-transplant exposure, prior transplant, and recipient EBV possibility. There are transplant-related factors, conditioning, T depletion, ATG, or HLA disparity, and post-transplant factor, GVH, immunosuppression, and EBV infection. For MDS, it can be genetic predisposition, pre-transplant exposure, age, conditioning as transplant factor, post-transplant factor, transplant therapy, age, gender, and lifestyle factors. Solid tumors, there are pre-transplant factor, genetic predisposition, prior exposure to this factor, age, gender, lifestyle factor, infection, especially HPV. Conditioning and T-cell depletion can increase. Chronic GVH is a strong factor for secondary tumor, and persisting immunosuppression, age, gender, and lifestyle factor. Late relapse depends on the disease status, T depletion in there, and the absence of GVH. There are very few observational studies and small series reported to the occurrence of secondary malignancy after cord blood transplant. And usually, sample size do not allow risk comparison with transplant using adult donor graft. So the aim of this study was to provide a general overview of secondary malignancy in cord blood transplant transplanted in EBMT-affiliated center over the last 3 decades. So this is a study design. It's a retrospective observational study using Eurocord EBMT database. The primary objective was survival since the diagnosis of secondary malignancy. The secondary objectives are to describe subtypes of secondary malignancy and to assess cause of death. We included all cord blood transplant between October 1988 to December 2018. All age, children and adults. Primary diagnosis was malignant and non-malignant disease, single and double cord blood transplant, and cord blood transplant rate we developed secondary malignancy. So we looked at 10,358 patients in 311 centers, and we collected 233 secondary malignancy. The median age at transplant was 31, and there were 36% children and 64% adult. 83% had a malignant disease prior to transplant, 15% non-malignant, and the median age at diagnosis of primary disease was 28 years. If we look at the primary diagnosis, it's mostly acute leukemia, MDS, lymphoproliferative disease, and the number after non-malignant disease was not very high. The highest was for bone marrow failure. When looking at the patient characteristic of the 233 patients, 54% had received a MAC conditioning, and 51% had received TBI. It was low dose, 30%, and high dose, 21%. 67% had received ATG, 94% alkylating agent, and 70% fludarabine. 41 had received a previous autologous transplant, and 12 had received a previous allogeneic transplant. The graft source was single cord blood, unmanipulated in 63%, and 33% had received a double cord blood. Considering HLA, 47% had only 0 to 1 mismatch, and 39% had 2 out of 6 HLA mismatch, and the number of cells was 4.7 10 to the 5th per kilo. So we analyzed the 3 types of tumors. PTLD was the most frequent. Median type since cord blood transplant was 3.7 months, and it was rare after 3 years. Acute leukemia, MDS, were mostly myeloid malignancy. The median time since cord blood transplant was 28 months. Solid tumors are increasing with longer follow-up. The median time since cord blood transplant was 4.5 years. So we will first discuss the post-transplant lymphoproliferative disorder. It's a heterogeneous group with abnormal lymphoid proliferation, usually of B cells, in the absence of effective T cell or other immune regulation of B cells. It occurs in the setting of profound immunosuppression after allogeneic transplant, related with T cell depletion, ATG use, unrelated or mismatched grafts, acute or chronic GVH, older age, and multiple transplant. The vast majority are EBV associated, the role of post-transplant EBV reactivation infection in the patient, inducing B cell abnormal proliferation in donor cells. UCB grafts are always seronegative, and so this increases the risk because the graft which is seronegative injected to a seropositive patient increase the risk of EBV reactivation in the patient. So there is no anti-EBV immunity provided by the donor. At least 57 of our patients who developed PTLD were EBV seropositive. So in these 145 patients, median time since cord blood transplant was 3.7 months. The time since we observed that most of the cases appeared early, mainly in the first year, but we still had some late occurrence of PTLD, 10% of the case, and we have rare cases 2 years after transplant. And this is probably related to prolonged immunosuppression for chronic GVH. And we have one case of Hodgkin lymphoma, which appeared 3 years after double cord blood transplant and with a good response to standard therapy. So when we look at these patients, most were adult, 61%. Most had malignant disease, and most had leukemia as primary disease. The 56% had received previous lines of therapy. 23% had received a prior transplant before cord blood transplant. 57% were EBV positive. The 40% had 2 to more HLA mismatch, and 16 received a second transplant after cord blood transplant. Most patients received the conditioning with MAC conditioning. 26% experienced acute GVH, 33% chronic GVH, which was extensive in 16%. So, the treatment for PTLD involved rituximab-based ATNA, and 12% received no rituximab and no treatment. The survival is very poor. Median survival is 2 months, and 20% are surviving after 5 years. So this is a very bad prognosis, and as you see, the attempt of treatment did not work for most of these patients. We observed several cases of late onset, so we focused on this one, 15%. We had 14 B-cell lymphoma occurring more than 1 year after transplant, and 1 Hodgkin occurring 3 years after transplant. So they seem to be a different cohort of patients. They had received ATG and prolonged immunosuppression. They were treated with rituximab plus chemo, or chemo and no rituximab, or no treatment because they died too fast. But the survivor at last follow-up, there is only 2 patients who survived. The patient with Hodgkin disease died of gastrointestinal bleeding in complete remission. So here also the prognostic is very, very poor, despite the attempts of treatment. So what can we do for that? We can do screening and prevention of EBV, screening patients at risk, prospective quantitative monitoring of blood EBV DNA, and start screening no later than 4 weeks post-transplant, at least once weekly, and the end of screening at least 4 months post-transplant, and longer if poor T-cell reconstitution. So can we do a preemptive therapy in this patient with high EBV level? Rituximab can be used with mixed results as a preemptive treatment. There is no specific threshold of EBV D anemia can be recommended for preemptive therapy. Rituximab and reduction of immunosuppression is possible, but doesn't seem to work very well. EBV-specific CTL should be considered when available. Antiviral drugs are not recommended, but there is no real study of using preemptive anti-EBV since the transplant for these patients. Now we will switch to acute leukemia and myelodysplasia. 23 patients were observed. Median age was 23. There were 13 adults, 10 children. Median time was 28 months. 12 patients were highly mismatched. And survival at last follow-up is 7 out of 23, and 6 of the survival were alive because they received a second transplant. The median follow-up for survival is 35 months. Primary diagnosis is mostly malignant disease, and the diagnosis of the subsequent leukemia was AML in 12 cases, ALL in 3, MDS in 5, and we observed 3 donor cell leukemia. So the risk factors were, these are very small numbers, so it means nothing, but it's mostly the same factor we see in all the patients. So if we look at more details, the median time is 1.5 to 4 years. The risk factors are well known. There is poor response to treatment. 7 of the 23 patients survived at last follow-up. Survival are those who receive a new transplant, and median survival is 9 months. So this is a mortality of 70%, mostly due to ALL MDS. So we observed a rare complication, which is donor-derived leukemia. So secondary donor-derived myeloid leukemia developing in the host is a rare complication after allogeneic transplant. Anecdotal cases are reported after transplant and UCBT. There are very small series reported. In EBMT, 14 cases, and there was no malignancy detected in donor cells before transplant. In Seattle, 12 cases have been reported, and in our study, 3 cases and 10,000 cases is now reported. So this is some detail of the 3 patients. They were 21, 34, they were adult. The initial diagnosis was different from the new leukemia, so it was easy to see that it was donor type and not the previous one. And the initial diagnosis for the patient was ALL, CML, and ALL. The graft source was single cord blood. The secondary malignancy was AML in all the cases. The time since transplant was 20 months, 17 months, 21, and the cytogenetic was unknown in 2 cases. So the detection of donor origin was blast cells are only karyotype in 3 cases, and the chimerism shows that they were 100% donor type. Now, solid tumors, it happens late. We have 65 cases. 58 patients had one solid tumor, but 7 patients had 2 or more solid tumors. The median age at cord blood transplant was 50 years, so it's higher than usual. 47 patients had more than were adult. Median time since cord blood transplant is 54 months, and most patients had a diagnosis of malignant disease before transplant, and 42% had 2 or more HLA mismatch. So what type of solid tumor? What is the risk factors? There is no identified really risk factor which is particular for that. There were previous autologous or allogeneic transplant, chronic GVH, new allogeneic transplant for graft failure, new allogeneic transplant for relapse of primary disease, so they receive more treatment than the normal patient. What is the type of solid tumor by frequency? The first one is lung, then it's thyroid. Sarcoma is relatively frequent. There is one bone sarcoma and one soft tissue and 6 soft tissue sarcoma. And then the other tumors are more rare. And you see that for people who had several solid tumors, it was breast, skin, lung, skin, thyroid, sarcoma, CNS, colorectal, upper gastrointestinal, CNS, neuroendocrine, so a lot of basal cell carcinoma. There is an increased cumulative risk with longer period of follow-up. Secondary tumors are comparable to those reported after other graft source. There is a high number of lung, sarcoma, oral, thyroid, and upper gastrointestinal cancer. TBI dose seems to be associated with thyroid cancer, osteosarcoma, and CNS tumors in the literature. So the mortality was 34% at 1 year, which is not so good, and 51% at last follow-up. And 40% of these deaths was due to secondary tumor. So survival at 5 years is 51%. Half of the patients with secondary tumor survive, so it's important to have a strategy to promote lifelong surveillance of these patients to avoid this complication. So if we look at outcomes, you see that it's not a good news to have a secondary malignancy after transplant. The worst is PTLD, secondary acute leukemia, survival is very poor, and even for secondary solid tumor, it's only 50%, which is not that great. And most of the patients die of the secondary tumor. So in conclusion, secondary malignancy after cord blood transplant are very rare. They are associated with poor prognosis. They are the main cause of late post-transplant mortality. The risk factors for developing secondary malignancy are similar to those reported in other graft sources: previous exposure to alkylating agent, to fludarabine, to TBI, ATG, number of previous therapy, previous transplant, prolonged immunosuppression. If we look at what we can do for PTLD, the incidence is 1.4%, despite the reduced intensity conditioning. The cumulative incidence is 1 to 2%, and 8 to 10% if multiple risk factor, mostly within the first year. It's very aggressive with poor response to rituximab and chemotherapy. There is a role of monitoring for EBV infection and preemptive care, and there is a poor outcome. Outcome may improve by EBV follow-up and post-transplant anti-IBV prophylactic treatment as long as immunosuppression. Promising result of new available and up-and-coming strategy might improve these results. If we summarize the secondary leukemia, incidence is 0.22% within 2 to 5 years, mainly of myeloid. Pre-transplant exposure plays a crucial role. There is a role for MRD follow-up. Donor cell leukemia are rare, but maybe they are underreported. Mortality 69%. And allogenic transplant gives the best chance of survival. For solid tumor, it increases with time. At 15 years, 0.56%. And there is no plateau in the incidence, and various risk factors depend on the type of the transplant. And it explains less transplant mortality, 49%. So I think the co-author of this publication and also my colleague at Eurocord in Paris, Anadi, Fernanda, Monica, and Chantal are located in Paris. Barbara, Graziana, and Fabienne are located in my office in Monaco because we have been sponsored by the government of Monaco to do this study. I am the head, but Annalisa Ruggeri and Vanderson Rocha are members of Eurocord and helping me to do this study. And Marina Cavazzana, Riyad Tamuza, Karina, and Waid are working after they came back to their own countries. Thank you. So if you have any question, I give my bad news, but I think it was important to do that.
Okay, there we go. Knowledge is powerful, so good or bad, right? With the EBV PTLDs, we don't routinely check our patients for EBV status prior to transplant, and cords would be considered naive. Do you recommend checking EBV status of the patient?
But when I saw this, I thought that it could be a good recommendation.
I mean, you know,
because maybe we can prevent with some antiviral drugs, or because as you have seen, it's not frequent, but it's extremely severe.
Well, we're using less
I was
ATG,
surprised by the mortality.
It's like CMV. We know ahead of time what our serostatus is for that. So it seems if we know our serostatus,
yeah, but as we
you
do
can check more frequently.
Check for infection, why don't add EBV?
We
do
generally
CMV,
do.
we do many things,
right?
And we don't do EBV. I don't know why.
We don't check pre, but post, we've started to do EBV, adeno, and CMV screening, especially if they've had ATG. But it seems it would be good to know ahead of time. So.
Yeah, but perhaps in this population the risk is increased because we know that EBV, most donors, adult donors, are EBV positive and have been, and the cord blood is naive and has no immunity. So I think in this particular population of patients, maybe we should be more careful.
Another issue regarding EBV, we do a lot of haplocords and we use ATG. We used to have a lot of problems with EBV proliferation despite preemptive therapy, despite screening. But 4 years ago, we started giving 1 dose of rituximab right prior to the transplant, and based on some data from England, and it has practically eliminated all EBV post-transplant lymphoproliferative disorder. We see it's very efficient, and we've reported that, and we have not seen any late side effects of that. So we see a little bit delayed immune reconstitution as far as immunoglobulins, but no increase in other infections. So it seems to be a very simple, quite effective procedure in these high-risk patients.
Yeah, I think it's. I think people should be more aware of that. Thank you.
I have a question for your secondary MDS. Because all the patients received alkylating agents. So, and they give you a lot of mutations in the stroma, in the stem cells, in the organs. So, but you see it only in adult patients, not in children, right?
Yeah.
Because the children have a better repair capacity for DNA as maybe your adult donors. So if you compare your data after allotransplantation, for instance, with breast cancer studies where you also get MDS frequently in the past treatments, so it's simply based on alkylating agents. Because these are also adult patients, they cannot repair so much. So, and even I think, I'm not sure whether you have the data, what about the patient who are getting alkylating agents in autologous transplantation or just for cure of leukemia? How is the rate there for secondary MDS?
I don't know.
Yeah.
No, what would be interesting is to compare our population with, for example, the patient in Japan, because they don't use I was thinking that I will ask Dr. Kanda that we can make a common study, because they don't use ETG in Japan. But they have other. So it would be interesting to make this comparison. We made several studies comparing Eurocord and Japan. And there are some difference. So maybe we could, I think it would be interesting to collect more about this secondary tumor and secondary malignancy. It will be important also for gene therapy, because if we know the risk factors and what can be the molecular basis for this type of malignancy, it would be interesting also for patients who receive now there is a lot of publication about secondary malignancy after gene therapy for sickle cell disease. And we are very interested by that, and we have been looking also in patients who have been transplanted for sickle cell disease. At this time, it's not very high, but the follow-up is perhaps not enough.
Okay.
And they are mostly children.
And I have another question. I wanted to ask Dr. Kanda, but maybe you can answer. He showed in the second slide that in an 8 of 8 match, he get a higher relapse rate. I mean, I think a higher relapse rate as compared to other studies, for instance. But is it based on the frequent haplotypes they have in Japan, that they have a high rate of homozygosity and only 3 frequent haplotypes?
Yeah.
That they are genetically different?
We are doing that now. But we compare the results of cord blood transplant in Europe and in Japan, so we have published 2 papers on that. In fact, the differences are not major.
Yeah.
We have some difference, but it can be only due to the numbers of patients and because we have looked at the survival and we have looked also to GVH. But there was no major difference, despite the fact that their protocol is quite different from the one we use. It's more similar because in Japan, there is a strict rule. They have to go through the protocol which has been approved. So they don't have the heterogeneity of what we have, because in our country, everybody does what they want. In Japan, you can't. So this is the reason why they have no ETGs, that they have cyTBI and busulfan. It makes a difference.
So thank you, Dr. Gluckman. I think the entire session was great. I would like to get a comment from you about something that is not completely related to your presentation, but it's still considered a cancer post-cord blood transplant. It is a donor-derived leukemia. And would like to know what is your experience, whether or not you think cord blood we see more cases of donor-derived when we use cord blood compared to other stem cell sources?
I don't know. It might be a defect of the microenvironment. There are some theories, genetic factors, but each time when there was leukemia on the donor, it was not found that the abnormality was found at birth, at least for the cord blood. In our study, we cannot, because it's a retrospective study, we don't know. So it seems to be acquired. It was probably not present in the cord when it was injected, but we cannot be sure. Do we have other question? I think we are on time. Thank you all for being there.